Anyway, I think everybody knows me. I'm Susan Palmianco, one of the nurse practitioners for the Cardiology B service, and I've been here since 2009, which is crazy, I think. And I'm really excited to talk to you about cardiac transplantation. These are my favorite patients, especially the post-heart transplant patients. I think the fact that we can actually remove somebody's heart and put another heart inside their body and it works and we make these people functional is crazy, amazing, miracle-like stuff. It's as close to a miracle, I think, as we get on a daily basis. So, I'm not sure if we can answer this, but hopefully. Did that work? Perfect, it did. So heart transplant is the treatment of choice for patients who have end-stage heart failure and they are now failing medical therapy. That being said, of course, they have MCS and that kind of all plays into it, but for patients that don't have some sort of device and they're failing medical therapy, this is the optimal treatment for them. The UW program has grown in the last 5 years significantly. When I started, we were doing about maybe 20 transplants a year. I think we had a really kind of bad year once, we did 15 not too long ago. And already we've done, 26 this year, and we're only halfway through the year. We did 37, I think, transplants last year. So our program is just growing leaps and bounds. So I think that's great. Let's talk about what we need to do to evaluate a patient for heart transplant. The pre-evaluation for heart transplant is the same as for LVAD. We use the same list. And there are 3 centers kind of in the Northwest that do heart transplantation, the UW, down in Oregon, the Oregon Health Sciences University, and then Spokane. Now there's some question whether Spokane's doing transplants right now. But those are the 3 areas, and then we get referrals from all over Washington, Wyoming, Idaho, Alaska is a big, Montana, so we get patients that come from all over to our center to be evaluated and to get a heart transplant. Referrals come in 2 ways, inpatient and outpatient referrals. Outpatient referrals come through a physician, and then Sue Moore, who is the transplant coordinator, RN3 in the clinic. She sets up like 4 days of outpatient testing to do the entire referral process, which I think is pretty amazing, as you'll see all the tests that are required there. Sometimes they come, they're so sick they actually get admitted, and we do the evaluation process once they're admitted. We also get patients that are transferred from other centers here locally and from Montana, all those places that we get referrals from. And inpatients that get referrals, we start them on the advanced heart failure pathway. I think the advanced heart failure pathway there is in your guide, so if you want to take just a quick look at that advanced heart failure pathway. This is the optimal of what's supposed to happen. This is kind of like a 3-day, everything gets done. I think it's actually 3 days, but when we did institute this advanced heart failure care critical pathway, we actually decreased our length of stay overall, and we saved like $7 million or something for the hospital in a very short period of time. So we did have shown that this has worked. We actually got some award and everything from the state. So, but what's supposed to happen, as you can see there in the left-hand column, is the the RN, the MD, ARNP, and what happens. They're supposed to be admitted, and then they get this CT surgery consult or an MCS consult or PICC line consult, and then their history and exam, chest x-ray. We initiate the diuretic protocol, which is something else I'm not going to talk about here today, but we can talk about that at a different time. And then going down is just kind of all the things that should be ordered or things that were expected on day 1. Then on day 2, you kind of start the social work, financial evaluations, physical therapy, starting all the lab workup and things. The transitions RN, who is Hillary Law, should come and see them and talk to them about heart failure and things. And then as it goes on, we just continue doing all the consults, which most of the consults, everyone gets a transplant infectious disease consult because they want to screen them for possible diseases, exposures that they've had. People have traveled all over the world. There are people that are have been exposed to TB in the past. We want to make sure that that doesn't become a factor once they're immunosuppressed. So transplant ID, everyone consults in them. Everyone gets a consult by a dental evaluation. People can't go into a heart transplant having some big infectious thing in their mouth, and it's an amazing amount of people that we actually pull multiple teeth, or I've had to pull all teeth in patients before transplant or an LVAD. Also, everyone gets a social work screen. Everyone sees palliative care so that we can make sure we're all on the same page and goals of care have been discussed in case something goes awry. And then there's kind of ancillary consults. For example, if they have hepatic disease, we need to have the hepatology see them. If they have pulmonary nodules, maybe pulmonary needs to see them. So there's all kinds of consults that go into the workup, and it can be quite extensive, and I'll go into this a little bit later about the hepatic workup, but that process can take a while. They might need a liver biopsy, and then it takes several days, and you have to get them off their Coumadin, and so this 3-day kind of timeline here is a little bit Pollyanna, I guess I would call it, but this is kind of the heart failure pathway, just something to be aware of. And I guess we can take a little, if you look at your MCS selection guideline checklist there. So this is the checklist that we use when someone says, hey, we should work this patient up for transplant. We have a book of these upstairs. It's not online anywhere, unfortunately. I get this out and I look at it, and I actually put the patient's name down there, and then I keep it. There's a little folder upstairs that we keep them in, and I start checking off the list. Okay, have they had, an angiogram? Have they had a right heart cath? Have they had all their labs? There's actually a transplant evaluation power plan that has all the labs on it when you go in under cardiology tab in the ORCA, so that it pulls up all of the labs that need to be done. Have they had vascular studies, a chest CT, PFTs? Everyone gets a pulmonary function test to screen for obstructive or restrictive lung disease. Patients who's over 50 and have not had a colonoscopy will need to have a colonoscopy prior to, and we have to have a GI consult for that. So you can see all the little check boxes that you have to do there. So that's kind of the evaluation. Let's talk a little bit about the indications for transplant. Obviously, anybody who's in cardiogenic shock, meaning they're on inotropes, they need a balloon pump, they have mechanical support, and then also patients who have persistent class 4 symptoms, even though they're on optimal medical therapy and their heart failure has progressed. These patients are candidates for transplant. And then there's patients with intractable angina. They may have a near normal ejection fraction and may not have that many heart failure symptoms. They may be about class 2, but they have chest pain that admits them to the hospital every week. I've had several 60-year-old males that I see weekly that come in for chest pain because you have to rule them out, and there's nothing you can do. They don't have disease that is amenable to surgery, so they have no surgical options. So these patients can be listed for transplant even though they have a normal ejection fraction and class 2 symptoms. There's also patients that have intractable arrhythmias, VT, and they're admitted, every couple of weeks. They've had multiple ablations that have failed. They're on maximal medical therapy, mexiletine, amiodarone, ranolazine, all of those things, and they still continue to have VT that they're symptomatic with. And so those patients also can be listed for transplant. And also let's not forget about the congenital folks. So People that maybe have the single ventricle physiology, you can't really grade their ejection fraction. And those folks, even if they're a little less sick than maybe your traditional heart failure patient with progressive heart failure, the congenital folks can get listed for heart transplant because they don't really have any other options as far as mechanical support. Sometimes we can put them on inotroves, but that can, although the other thing I wanted to say about the congenital folks is we're seeing a lot more congenital people because 20 or 30 years ago, the congenital corrective surgeries were advancing and they've lasted about 20 years, but now these corrective surgeries like Fontane's and things are failing, and so we have all these 30 and 40-year-old congenital folks that we haven't really known what to do with before, so we're kind of making up the rules as we go along as these folks have lived longer. Contraindications to transplant. I think Jennifer mentioned the pulmonary hypertension, which is one of the biggest contraindications to transplant. So if you have, what we use to evaluate pulmonary hypertension is the transpulmonary gradient, or TPG. So when patients get a right heart cath, we get their PA pressures, and then and you get a wedge pressure. And to measure TPG, you use the mean PA pressure and you subtract the wedge pressure and you come up with their TPG. Our cutoff is about 15, and remember, if this pressure is too great, then the new heart is going to have RV failure. And as she said, we use the phosphodiesterase inhibitors, either sildenafil or the mechanical support will lower these pressures and prepare these patients to become eligible for transplant. Malignancy, if patient has had a malignancy, they have to be cleared by hematology or oncology and have to be given at least a 5-year free survival of their cancer. Of course, patients with any active infection are not a transplant candidate. Age greater than 70, we have a fair amount of patients in their 60s, late 60s, and our age 70 cutoff it's a little bit wavy. I think the age cutoff is different for other centers. And this is being discussed a lot now, and so I think that the guidelines may be changing in the process of changing. But if there is a pristine 69-year-old patient and they don't have any other comorbidities or organ failure, we will probably list them, or even a 70-year-old. We have transplanted a 71-year-old, I believe, but he had, he was just completely pristine, and that went well. But it's an ethical thing about allocation of organs, and if there's 20, 30-year-olds waiting on the list, and who do you give the organ to? We also, contraindication is patients with diabetes who have end organ damage. For example, if they have peripheral neuropathies, or they've had amputations, or retinal disease, or something like that, or if they have uncontrolled diabetes. We actually make patients that have hemoglobin A1Cs that are too elevated, we make them show control and get their hemoglobin A1C down before we will actually list them for transplant.
Do you actually have a number that you make them target?
I think we want it below, I want to say 7.5 or 8. I think if it was 8.5, we would make them go 3 more months and show control. BMI greater than or equal to 40. Patients, there's been studies that have shown that if your BMI is too high, that surgery doesn't go well. Advanced obstructive restrictive lung disease. We're always afraid we won't get those patients off the ventilator, or that they're at risk for increased infections, as patients are with recent PEs, higher risk for infection. The advanced hepatic disease, as I alluded to before, there's a lot of congenital patients, or patients maybe with some right heart failure that have had hepatic congestion for many, many years, and then they have these huge livers, and maybe they have ascites. So we do an extensive workup on, what is their, what's their MELD score for one thing, they go and see hepatology. Most of these patients will have a transjugular liver biopsy done. They'll get wedge pressures and see what the gradient is in their liver, and then they'll get the biopsy. Any patient with cirrhosis is not a candidate on the biopsy. There is a lot of gray in bridging fibrosis versus cirrhosis. And the reason is patients with liver disease, they just bleed like crazy when you during the actual surgery. We had a couple of patients early on that maybe the liver workup, we weren't as stringent in the past about the liver workup, and I'm sure you remember this, Carrie, that the patient, maybe you weren't over there then, but just emptied out the blood bank with as many. There was multiple people squeezing bags of blood into this patient after her transplant. She was congenital, and that did not go well. And then moderately impaired renal function, obviously somebody with a creatinine of 2.5, and then you're gonna put them on a bypass run. What's gonna happen to their creatinine after that? It gets a little bit concerning. If the patient qualifies for a heart-kidney transplant, that's maybe one option for them. But that's something you really have to be careful of and aware of. And then, of course, the substance abuse is something that's contraindicated. We make patients, we're working on kind of a standardized protocol and contract for each patient, but each patient currently gets a contract that's at least 6 months long. They have to, if they've done, they have to show that they've gone through a treatment program, and then that they're attending AA or NA, and signatures and formal evaluations and stuff like that. And social work is then in charge of making the contracts, signing it, and then we do random drug screening every time they come in. This is for smoking, alcohol, and illicit drugs, so we don't allow any of that. And the test for smoking, in case you guys don't know, is you can do urine nicotine and urine cotinine test, and the cotinine is the difference between secondhand smoke. So, because patients come in and say, oh yeah, no, I wasn't smoking, that's my wife, or I had friends over and my friends were smoking and I was around smoke, but we can detect whether it's the person smoking or if it's secondhand smoke. Very tricky.
So if the cotinine?
If the cotinine is positive, that's for secondhand.
That's secondhand,
yeah.
But if the nicotine?
If the nicotine's positive, then
it's first hand.
Right.
I see. And how long do they have to be clean?
At least 6 months, but the contracts right now kind of vary. That's where we're working on a standardized protocol that it'll be the same for each patient, because there's some people that have just used and maybe not abused, and so there's a lot of, in fact, there was a lot of emails this week and going on about this new policy that so I don't think everything's been quite hammered out, but I think it's a minimum of 6 months for all smoking, alcohol, and other drugs. And whether that's gonna make, do longer for, illicit drugs, I'm not really sure. But stay tuned. And then also Jennifer mentioned our selection committee, which is on Thursdays from 8 to 9:30 every week. And it's Erin Wilson. I'm not sure if you've met her, but she is the one of the transplant administrative coordinators. And every week, people that are ready for presentation, they've gone through, whether it's in the outpatient department or inpatient department, they've finished their evaluation. Physicians or nurse practitioners will just email Erin and say, hey, this person needs to be presented this week. And she will make up electronic packets and then send them out to everybody so that everybody has access to look at these packets before. And then when you get to transplant committee, either a physician or one of the fellows, or if you really wanted to present the patient, I'm sure that would be fine, presents the patient to the entire